from the American Academy of Pediatrics.
The pandemic created several barriers to HPV vaccination in the United States.
That means an increased push for earlier initiation and the campaign HPV by 9.
It really gives you 4 years to get the vaccination done, so 4 potential years of touch points with the parents.
But first, it's October, and we're teeing up a research roundup.
We want to make sure that when we order a test, a procedure, a practice, that it's going to do right for the children we care for, that it's going to be cost effective, and it's going to give us outcomes that can hopefully help us make a diagnosis or get these kids to feel better.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a look at practice-changing articles from the journal Pediatrics.
Joanna, it's already October. Have your kids chosen their Halloween costumes yet? And most importantly, are you and Danny going to dress up?
Halloween is so fun in Philadelphia. The city gets dressed up. We already have the kids' costumes, but that could change in a month. We'll see. And I've been trying to settle on one costume and add to it every year. I have a witch getup that's just like screaming for a new broom. What about you, David?
I really miss trick-or-treating with my kids, but I may not want to know what they're wearing this year. I don't want to wear a costume that would scare our neighborhood children. So I'm thinking of wearing something instead that would scare me. But I can't find a costume that just shouts not up to date with the pediatric literature.
Ooh, this is a fun game. Maybe you could go as an inclined sleep surface or a button battery. Nothing scares pediatricians more than that.
That's pretty terrifying.
I know someone, though, who can help us decide for you, David. He's creative, and sometimes his humor scares me. The editor-in-chief of Pediatrics, Dr. Lewis First.
Joanna, David, it is great to welcome the fall season with you. And needless to say, I was going to dress as a podcaster, but you've already got that covered. So maybe instead of some tricks of what we do, we provide some evidence-based treats in the October issue and tell you what pediatricians need to know that may actually change their practice.
Oh, that sounds sweet. So let's start with something that used to scare us and maybe is a little less scary now that we have a vaccine, human papillomavirus. This infection has been a common cause of cancer in the past, but Lewis, can you predict our future?
Well, the 9-valent human papillomavirus vaccine was licensed in 2014 and was tested a few years before that, as you can imagine. And the question is, 10 years plus later, is it still immunogenic? Is it still effective? And those were questions that have been answered by Dr. Jaime Restrepo and colleagues. He's in Medellin, Colombia, colleagues from countries all over the world who decided to follow the original cohort who tested this vaccine in 13 countries, 5 continents, and got about 1,200 youth, older children and teenagers between 9 and 15 to volunteer to be followed for at least on average 10 years after they got the original 3 doses of the 9-valent human papilloma vaccine. Remember, this is a vaccine that protects against 7 types of HPV that have been associated with cervical cancers and 2 more types that have been associated with genital warts. And so this study basically had these 1,200, I would say, older children and teenagers coming in to get antibody testing at periodic times over 10 years. And also, they were very good to volunteer, but they also decided they had genital swabs assessed on these kids beginning at age 16 to look for evidence of HPV DNA by polymerase chain reaction. And they did external genital exams. And then 10 years later, they said, how are we doing? And the good news is that the immunogenicity of the 9-valent human papilloma vaccine is excellent. 80 to 90%, depending on the immunoassay you use, of these particular children or teenagers ended up having very strong titers against the 9-valent human papillomaviruses that were being defended with this vaccine. In addition, the effectiveness was remarkable in that there were no cases of any human papillomavirus associated types of cervical cancer and no genital warts associated with the 9 types that this vaccine protects against. This is pretty remarkable 10 years out. They also looked at safety, and there were no adverse effects. They even followed pregnancies, and there were no problems 10 years out. So This basically speaks well to saying a 9-valent human papilloma vaccine is the way to go, except there were no controls. So you might say, well, what's happening to people who didn't get the vaccine? And the investigators look back when they tested the quadrivalent vaccine 10 years later and got the same kind of outcome. So they inferred this is very similar. Now we're protecting against more strains of HPV, and that's good. They also said, well, maybe this cohort of teenagers was not sexually active as much as the general public. And they said, well, wait a minute. We have that data on the quadrivalent cohort. And again, this group was just as sexually active and had just as many sexually transmitted infections, but nobody was getting human papillomavirus. So all of that is good. And your final question, I can see you both looking at me saying, well, we're on a podcast. So listening to me and saying, well, we give that vaccine twice now, 6 months later to children between 9 up to 15 years of age. This was 3 doses at T0, 2, and 6 months. How do we know that the 2-dose regimen of the 9-valent vaccine will work? And again, in the discussion section of this study, and I don't think I'm doing it justice to note the numbers of results that show the effectiveness and immunogenicity, but they make a lot of points compared to the quadrivalent vaccine, as well as 3 years into the 9-valent vaccine to say the titers and the effectiveness are just the same with the bivalent as well as the trivalent. So those of you who are giving 2 doses of HPV, you can be reassured through this article, and then studies will come that this is one heck of a good vaccine to think about. So if you have families in your practice who are wondering whether they should give their children the HPV 9-valent vaccine, I would give this one your best shot and boost their confidence. We're doing a few vaccine puns for the season. Boost their get the boot. Okay. And show them the results of this study 10 years later. And I think this is the kind of protection we want for our kids. This is a terrific vaccine, and the 10-year follow-up study will help other families understand who may be skeptical that this is the way to go.
Well, Louis, let's go from boosting to booing. I don't want to lose that Halloween spirit here. So let's pivot to a threat that maybe should scare us more than it has: urinary tract infections. What do we know about interpreting urine cultures from catheterized specimens? As a hospitalist, this is one that haunts me for sure.
Well, it does haunt you because this is one of the riddles for the ages. I mean, there's the riddle of the Sphinx. There's the riddle, how much wood can a woodchuck chuck if a woodchuck could chuck wood? And then there's the, what is the cutoff of colony-forming units per milliliter on a urine culture to convince me that my patient has a urinary tract infection? So it is with that in mind that Dr. Nader Sheikh from the University of Pittsburgh and colleagues did a terrific way to answer that question by not just looking at plates and cultures, but found a new way to determine a urinary tract infection, or used a new way, which was ribosomal RNA gene sequencing. So here's what happened in this study. The authors enrolled 341 febrile children from 1 month to 3 years of age who had no focus of infection except fevers, came into the emergency department, underwent bladder catheterizations, got a urine specimen, sent that urine for culture and also for gene sequencing. A urinary tract infection was defined as when the gene sequences in a sample showed 80% abundance of one genome of an organism that would be associated with a UTI. So if they kept seeing gene sequences that said this is E. coli, 80% of the time they said that is going to be consistent with a urinary tract infection, but they combined that with adding in inflammatory markers to just confirm that. Because as you start to get lower and lower in your colony counts, you might say, well, maybe my sterile technique wasn't quite as sterile and it's a contaminant. The urinary markers were white blood cell count in the urinalysis, the leukocyte esterase, and the neutrophil gelatinase associated lipocalin, otherwise known as NGAL, which is really a biomarker that's now being used in many laboratories that basically is an inflammatory glycoprotein released by neutrophils or cells in the kidney that say this is pretty highly sensitive and specific for a UTI or certainly for some kidney disease. So if they then took that information and went to urine cultures, they found the following: that if they had a urinary tract infection by the gene sequencing and they made the cutoff 10,000 colony-forming units per ml, the authors found that the sensitivity and specificity of that urine culture showing an infection was 98% for sensitivity, 99% for specificity. Now, we've been thinking, is it 50,000 per colony-forming unit, 100,000 per colony-forming unit? These were all bladder catheterizations, but if you use 50,000, the sensitivity drops to 80%. And if you use 100,000, the sensitivity drops to 70%. So many people have been using 50,000 units per colony forming unit. This is a study that starts to say maybe, in fact, we should be using 10,000 colony forming units in association with inflammatory markers. So what's the problem? Should we make that change now? Well, this was 341 specimens, of which only 46 were positive with gene sequencing for a UTI. And 45 at 10,000 colony forming units per ml became positive as well on the culture plate. So basically they got 45 detected with culture compared to 46 with gene sequencing, which basically says conventional cultures remain a great way to diagnose UTIs, but the cutoff of 10,000 is probably the optimal balance for test characteristics versus 50,000 or 100,000, assuming you also get some inflammatory markers showing up as well. So does this mean that based on 46 UTIs, everybody's ready to use 10,000 colony forming units? People are saying, well, wait a minute. That's a lot of false positives that may come in. That's a lot of kids on antibiotics. That's a lot of kids perhaps getting their kidneys imaged unnecessarily. So we got a commentary. We got a commentary from Dr. Ellen Wald and Dr. Jens Eickhoff at American Family Children's Hospital in Madison, Wisconsin, who basically cite, first of all, the strength of this study using something other than just comparing cultures to cultures, but using gene sequencing to look at cultures. They then stress the importance of the inflammatory markers to rule out the false positives. And then finally gave us other studies in their commentary that suggest when you do a suprapubic bladder catheterization and some other different studies that you really can find infection below 50,000 colony forming units per ml. So I think our listeners should go with the flow and listen to the stream of information that is being imparted through this study and commentary, and really consider going to 10,000 colony forming units plus inflammatory markers when it comes to defining what is a positive urine culture.
Thank you for that, Louis. And let's talk about one other topic before we go. It's one that I know gives David nightmares: unnecessary medical tests and treatments. Do we have a better description of this many-headed monster and how we can keep it under the bed?
Well, we don't want to make any overuse boo-boos during the Halloween season, do we? So let me unmask a special article we are publishing in the October issue from Dr. Nathan Money at the University of Utah and colleagues from around the country that's called an update on pediatric medical overuse. Now, we all want to provide high-value care. We want to make sure that when we order a test, a procedure, a practice, that it's going to do right for the children we care for, that it's going to be cost effective, and it's going to give us outcomes that can hopefully help us make a diagnosis or get these kids to feel better. So what Dr. Money and colleagues have been doing has been, actually, this is the fifth article since 2017, where they take a look at medical overuse in the peer-reviewed literature on an annual or biannual basis. And they do it by doing a Medline search. This particular feature article, special article, looks at research articles, original research from 2021 through 2022. They did a Medline search looking for terms like overuse, misuse, unnecessary, inappropriate when it comes to pediatric treatments, procedures, or practices. And then they also did a manual search of titles of tables of contents over those 2 years of peer-reviewed journals that deal with pediatric studies and are high impact. From that, they got 201 studies in 2021, 2022 dealing with medical overuse, pediatric medical overuse. They used a scoring rubric to cone it down, and they present us in this special article with 10 key articles that they feel really need to be considered by pediatricians for de-implementation, or certainly let's reduce the frequency we're doing these things. And they group them into 3 themes. Now, we don't have time today to go through all 10 articles, but I want to share the themes because I think this will get listeners to say, we need to check this article out. Theme 1 is articles that question our routine practice. And as a teaser, there's one by Dr. Rebecca Dang and colleagues from Stanford looking at the taking of routine temperatures during health maintenance visits, which, again, each of these 10 articles in this feature article, special article, deal with the background situation, the findings in the study, the limitations of the study, and the implications for all of us who practice pediatrics that we really need to pay attention and reduce the overuse. So there's one on routine temperature measurement. They deal with articles in regard to prolonged duration of antibiotics for mild community-acquired pneumonia. There's articles about routine dental x-rays we shouldn't be getting, about longer birth hospitalizations, Joanna, in the nursery when kids may not be readmitted if they go home sooner. And of course, they talk about the importance of skin-to-skin, particularly in lower middle-income countries where babies in incubators may not be the best thing for getting these kids and keeping them healthy. So that's a teaser of theme 1. Theme 2 are articles that support judicious surgical referral. And what they're saying in these 2 studies that they cite is we should be careful how many kids we automatically say they need a gastrostomy tube when we might buy some time with a nasogastric tube relative to complications that occur with a gastrostomy tube. They do the same thing about tympanostomy tubes. There's another study that comes in, and some of these are in our journal, some are in other journals, that take a look at don't put those tubes in just because you think they're going to reduce the incidence of acute otitis. And finally, the third theme that's discussed in the overuse article are articles that demonstrate the adverse effects of pediatric interventions that are commonly overused, like, can you say, over-the-counter cough and cold medications? We know this is not in the best interest. This is overuse palooza. They also cover proton pump inhibitors and getting a tonsillectomy in children with medical complexity, where they will share an article that discusses significant morbidity and mortality. Again, I could go through the authors and the journals, but I really want our listeners to get to this feature article and look at these 10 studies and then think how they can incorporate them into their own practices. I'm not a fan of overuse, but I do hope that our listeners use and overuse this special article, because I think it will make a difference in de-implementing practices that are not well evidence-based, and yet we do them. And this special article will tell us to do them a little bit less. And that is a treat for the Halloween season and every month of the year.
You know, that is a big bucket of candy for me right there, Louis. Before you go, we have to know, how are you going to celebrate Halloween this year?
Well, my family thought I might dress up as a pediatrician, but then they said that would be too scary. So I'm going to be the greeter. And I hope that if all the listeners want to come by, seeing everybody in their Halloween costumes, safe Halloween costumes, remember, don't wear those masks, right? Want to give people a chance to breathe and keep those. Well, we can do Halloween safety. It's a whole different segment. But I really want to make sure that Halloween is a safe and healthy treat for everyone, not a nightmare, nothing scary, but most importantly, as much as October is a treat, wait till you see what the harvest brings in November for our journal, Pediatrics. Happy Halloween, everybody.
Happy Halloween, Louis. To read the articles we talked about today and more, just go to aap.org/podcast.
Coming up, we'll look at increasing HPV immunization rates by initiating the vaccine at age 9.
The HPV article Louis just talked about is so heartening. I remember getting the original HPV vaccine as a young adult back in 2006.
You know, I never got it as I was over the recommended age of 26 when the vaccine was first released, but I made sure my kids got it right at age 11, the recommendation at the time.
I'm definitely getting my kids vaccinated for HPV, but because they're really young, I'm guessing I don't have to worry about it for a while.
Well, since 2018, the AAP has recommended the HPV vaccine for children ages 9 and older. So maybe it's not as far off as you think.
Oh, I didn't really realize that. My bias is to think HPV vaccine is for teenagers. And the AAP champions so many vaccine initiatives. I want to know more about this one. And I know who we can chat with about it, David. Dr. Sherry Zorn.
She's a great person to discuss this with. Dr. Zorn is a general pediatrician who is a quality improvement coach and physician motivator in Seattle, Washington. She's been on the HPV-free task force and part of an HPV Vax at 9 implementation group in Washington state. Dr. Zorn, welcome to the show.
Thank you very much. I'm pleased to be here.
Let's start by talking about HPV. How prevalent is it in the United States, and do you consider this virus to be a sexually transmitted infection?
So HPV is super common. Almost all of us will be exposed to it at some point in our lives, usually in the teens and 20s. And yes, it's true, it is a sexually transmitted disease, but you know what? You don't even have to have sex to get it, just intimate skin-to-skin contact. So I like to get away from this idea that it's sex or what is the definition of sex and just say, let's reframe it. It's cancer prevention. So I'm uncomfortable sometimes trying to talk about the different ways that it's transmitted. So I like to talk about cancer prevention and not get stuck in the weeds on the sex issue.
What cancers can HPV cause?
HPV infection, when it's persistent, and I want to just point out that it usually goes away spontaneously for most of us, but when it's persistent infection, it can cause 6 different types of cancer. The most common one that we think about is cervical cancer for women. That's the highest numbers for women. But oropharyngeal cancer, which is cancer of the back of the mouth, the throat and tonsils, that's more common in men than in women. So those are 2. And then the other 4, which are much less common, are cancers of the anus, penis, vagina, and vulva. So I really think about cervical cancer and oropharyngeal cancer as being the 2 most important ones that we really need to be focusing on.
You know, as a former internist, that really speaks to my interests. So what is the average or standard age of vaccination against HPV in the United States? And why did the AAP start recommending that children as young as 9 get the vaccine?
Well, the routinely recommended age is age 11 to 12, but ACIP recommends 11 to 12, and it can be given at age 9. So we've been able to give the vaccine at age 9 all along. In 2018, the AAP published their new Red Book guidance that HPV vaccine should be given at 9 to 12. And really, I think the reasons why, and I'm not on that committee, but they realized that HPV vaccination was really lagging far behind the other vaccines in the adolescent bundle, the Tdap and the meningococcal ACWY. And because the bundle really wasn't working, they looked at strategies for how could we increase immunization rates so that we can prevent cancer. That's our goal, prevent cancer. And really what they came up with is if we start giving it earlier at age 9, we'd have 4 years, sort of this window of opportunity to get kids vaccinated, and we would increase vaccination rates. So AAP did it to increase vaccination rates and to prevent cancer. That's really our job.
Sherry, you've been an age 9 HPV vaccinator since 2017. What inspired you to make the change?
Well, I could actually talk about this for about an hour. There are so many benefits and absolutely 0 downsides. So I'll try to condense my talking points because literally I'm so excited about age 9 and I would never go back to age 11. But a couple of things. I like to say that it's better for patients, parents, and providers, and it's easier too. So anything that's easier and better seems to me like a real win-win. So easier, what I mean by that is it allows for easier conversations, really focused on HPV vaccine as cancer prevention, and you don't have to get into that awkward sex talk. Parents prefer that and providers prefer that. It also allows for fewer shots per visit. And a lot of patients and parents only want 1 or 2 shots per visit. They say, I have 2 arms, I want 2 shots. And in fact, even a lot of providers don't like to give 3 or more shots in a visit. So patients, parents, and providers really do prefer fewer shots or they like to space them out. And I mentioned this before, but it really gives you 4 years to get the vaccination done. So 4 potential years of touch points with the parents. So if there's like a disruption in care, like the pandemic, you can plan around that. If a parent is hesitant and they need more time to learn about the vaccine, you've got 4 years to slowly work on that hesitancy. And really, most importantly, starting at 9 results in higher on-time vaccination rates. And on-time vaccination means completing it by the 13th birthday.
So I am really eager to do this with my clinic patients, but when you introduce this idea to families at age 9, how do you frame it? How do you talk to them, and what do they say?
Well, you start out with a strong announcement approach recommendation, and you just say, now that John is 9, he's due for his HPV vaccine, and it prevents 6 types of cancer. We should get it done today. So you start simply as that. And parents might say, I thought that was 11. And in our practice, we just say, you know what? Science shows at age 9 it works better, so we do it at age 9. And most parents will say, oh, okay, that sounds great. Some parents might say, wow, we really weren't prepared for a shot today, but since it prevents cancer and it's so important, we'll get it done. Or I promised my son or my daughter that we wouldn't have any shots today, so is it okay if we just do it at age 10? And I'll say, sure, no problem. But my whole goal is to get the kid vaccinated before 11. Because if I can get one shot in at 9 or 10, or even both shots in before the 11-year-old bundle, I know when they come in for the bundle, I can catch up any kids who need their second dose.
For clinics that haven't already started offering the vaccine at age 9 and want to change their workflows, how do you recommend they do it?
Well, first off, providers just need to know that it's absolutely okay and encouraged, and it's actually a really great idea to do age 9. So providers sometimes aren't really sure about this. They think it might be contradicting the ACIP guidance, and it does not. It completely goes along with the ACIP guidance and the AAP guidance. So providers just need awareness. And then once they're willing to do it, they just have to give it a try and give that strong announcement approach. And I'll just say, when I was an expert bundler. I could get almost any kid vaccinated with all 3 vaccines at 11. I'm an expert at that. So when I first tried to unbundle the vaccine recommendation, it was really awkward. I was sort of scared of the 9 and 10-year-olds, like how would this go? And what if they asked me about HPV vaccine because I'm not sandwiching it in between the other 2 vaccines? I'm just putting it out there all alone to have them ask me any questions. So it was scary. But what I found is that the parents, when they had questions, they were pretty easy to answer. Like, oh, is it for boys too? Or, oh, it's at age 9. Or, oh, I didn't realize it prevented cancers. They were pretty easy questions to answer. And if they had hesitancy, I only had to give them 1 or 2 kind of points to answer their main concern. And I didn't feel like I had to data dump and absolutely twist their arm and get them on board that day, because I knew I'd be able to talk about it with them again at age 10 and at age 11. And at age 12. Usually you don't have to keep talking about that many times, usually just once or twice, and they'll say yes.
For years, the messaging was that HPV caused cervical cancer. Now we know it causes the other 5 cancers you mentioned. Are parents surprised when you tell them that their boy should have it as well?
They often are, because most people don't know that oropharyngeal cancer is caused by HPV. And 4 out of 5 cases of oropharyngeal cancer are in men. So once they understand that, they kind of go, okay, this is a real issue for my son, or could be an issue for my son, years and decades later. So I need to get my son vaccinated too. There are barriers. The first barrier is probably awareness and pediatricians being confused with whether age 9 conflicts with ACIP guidance or not. And it doesn't. It completely complies with it. The other barrier is that often when they try to change their electronic medical record prompt to age 9, they'll receive pushback from their EMR or IT team. So that's a struggle. And there are a few things that could be done to really promote age 9 on a national basis. One is, if the elephant in the room is if the ACIP would please change the guidance to a stronger recommendation at age 9 that would really harmonize with the AAP's recommendation of 9 to 12. This would go a very long way, because everyone looks to the ACIP and the wording. And even though they've always said it can be given at 9, I'd like to have them say it should routinely be given at 9. Then the next thing would be for large electronic medical record systems such as Epic, if they could change the prompt so that it'd be easier for clinics to institute an age 9 prompt. This would be a provider reminder. So providers don't have to remember to do this. It just comes up on their electronic medical record prompt and prompts them to do it. And then state registries, the immunization registries for states and jurisdictions, they can also work as a provider reminder by changing their prompt for first dose of HPV to be due at age 9 instead of 11. We just did that in Washington State in January of 2023, and this has already doubled our rates of HPV vaccination at age 9. So it's a really powerful additional prompt that can help make change across the entire state or region.
Speaking of entire states or regions, have you taken this message outside urban areas? What has the reaction been?
Well, that's an excellent question. And we know that there's more HPV vaccine hesitancy in rural settings. So after having our great success in the suburban and urban settings in Seattle area with HPV at 9 recommendations, we then started coaching clinics across Washington State, specifically in rural counties. And I really wasn't sure if my approach would work in the rural setting. And what we found was it really absolutely does. The rural providers said, the majority of them said this is much easier, and only a small minority, 9%, said it was harder. So the rural providers in our 5 clinics that we just finished coaching, they said this was better and easier, so much easier than COVID vaccine, which was super contentious for them. And they also said that the parents were really open to the HPV at 9 message as cancer prevention. So this was a big surprise for the rural providers, but they were excited that they finally had something to do that was easier and going to really help decrease HPV cancers in their populations.
Are there any other surprises you've encountered in your coaching? Maybe a tool that worked better than you expected?
The only other thing would be the putting it into practice in your office. We really just talked about the announcement approach in the office, but getting the messaging right in your office, kind of a consistent messaging that HPV is cancer prevention focused on age 9. And in my practice, I like to do it with low tech and high tech ways. High tech would be EMR prompts, but low tech ways would be an HPV poster in the lobby or the exam room that educates patients just literally on HPV as cancer prevention starting at age 9. And also my favorite intervention, and this has actually been the clinics that I've coached, I've really said this is the most important, is posting a large poster of the simplified immunization schedule that really reflects each practice's streamlined workflows. And it features HPV starting at age 9. And they have said this is the number one thing that they can do. It's on the wall. It's a conversation piece. Parents are always asking about it, and it basically shows the parents this is due next. So even parents at ages 7, 8, they might look and go, oh, it looks like next year we have a shot at age 9. It's HPV. Doctor, can you tell me more about that? And you can start the vaccine conversation much earlier, and it's very short tidbits of conversation. I'm not talking about a long conversation. I'm talking about 15 seconds, 30 seconds. And that's sometimes all a parent needs to then be ready to vaccinate at age 9.
Sherry, before we let you go, do you have any last pearls or takeaways to share with our listeners?
Well, for takeaways, a couple things. There's a window of time when HPV vaccination works best. It's 9 to 12. So you want to get everyone completed by their 13th birthday. And if you start at age 9, it's a much higher chance that you're going to optimize vaccination rates during that window. And age 9, like I mentioned, is easier and better. And as pediatricians, we all need something that's easier. So easier and better. And finally, for those that aren't sure about age 9, there's a mounting body of evidence in support of age 9 recommendations. And these are published in the volume 19 of the Journal of Human Vaccines and Immunotherapeutics. It has everything from quality improvement projects, policy issues, why the AAP recommended at age 9, why they made their initial change in 2018, and studies on showing that it does actually work and increase vaccination rates by the 13th birthday.
Dr. Sherry Zorn, thank you so much for joining us today.
Thank you.
To read more about the HPV vaccine and HPV at 9, go to our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, one of the joys of having adult kids is watching them do things you never imagined doing yourself. So I talked before about how my youngest, Julian, is taking climbing lessons. But my middle Sellers told me yesterday that it was the quarterback for his intramural football team, which, Joanna, you've known me for a few years now. You know, nobody is picking me for anything but Waterboy. So I'm like, wow, where did you pick that up? That's incredible.
That is so incredible. I'll throw in an athletics Say as well, which is that we finally started my daughter in gymnastics.
Oh, cool.
And I think she is just really enjoying it. She is the type of kid that bounces. We specifically got a coffee table that is sort of like an ottoman. because she's never still on the couch and she bounces around. And I know as a pediatrician that sounds dangerous, but you try to stop her, you know?
No.
But I think she's really enjoying it. So still yet to see what her athletic prowess is, but I'm glad your son has found his.
They keep surprising us as they grow. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about low-carbohydrate diets in children and adolescents with or at risk for diabetes.
We'll talk to one of the authors of a new clinical report, Dr. Tamara Hannon. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinki. Thanks for listening.